All right, so we're gonna move right along and yes. While she pulls up Jessica's talk, if any of you haven't met Jessica in person, maybe you've seen her on LinkedIn. That's how I found her. She would do these posts, kind of similar to some of the post-it note things that we see on the research side, but bringing, T-SNE into looking at clinical data. And so I was like, hey, Jessica, let's come on out. To sit on the panel because it's really important to me that we have the technologists and the hematopathologists leading this effort, but B, because I like the way that she analyzes data and how innovative she is. So she is ASCP certified, 20 years of clinical flow cytometry experience, and she loves developing teams devoted to quality patient care and leading them with cutting edge science and technology. So she's currently serving as a staff scientist at the City of Hope. So help me welcome Jessica.
Thank you so much for having me. Can I get a laser on here? Maybe. So Stacy did a really good job of letting us know why MRD studies are so important. And we're going to go over a case of how we use T-SNE to assist us with our B-lymphoblastic leukemia, MRD. So we all know that MRD studies are important, but what I want to drive home is how challenging they can be. They're really tricky to analyze and interpret for a number of reasons. In our lab, we're collecting 1 million cells, and you're looking for a really tiny population in those 1 million cells. Sometimes these abnormal populations will read the textbook and express what you want them to express, but sometimes they won't. Or sometimes the patients have been heavily treated, like they often are in our lab, and so they just don't look the way they looked at diagnosis. And also in the case with B-lymphoblastic leukemia, we have to separate them out from the normal hematogones, which can also be kind of tricky. So we have been playing around with T-SNE as a way to help us with our analysis. And for right now, it's kind of like, it's like In-N-Out Burger if it's on our secret menu. So the pathologist will ask for it in tricky situations. So we have not yet converted to spectral. We are still doing 10-color flow on the Navios. So we have a 2-tube BLL MRD panel. Tube 1, as you can see, has CD19 to identify B cells. It has like CD10, CD34, CD38 to identify hematogones. We have stacked CD66C, 13 and 33 as markers of aberrancy. We have markers like 58 and 81, which will show altered level of expression in abnormal immature B cells. But tube 2 is a totally different idea, different way of approaching it. As you can see, we don't have CD19 in tube 2 because we didn't want to be too reliant on that because, it's often a marker that they're targeting with treatment. So we stacked a bunch of markers to exclude myeloid cells, monocytes, NK cells, and T cells. And with what we have left, then we're looking at things like CD22, CD24. We're looking at markers of aberrancy like CD304, CD123, CD73. So it's 2 very different approaches. So our case today is a bone marrow sample, day 174 post-stem cell treatment. The previous MRD studies were done on day 100. They were negative by flow and clonoSEQ. So I'm going to first take you through our traditional gating strategy with tube 1. So we start by eliminating the doublets and debris, of course, and then we focus on this low side scatter region, even including the high CD45 cells, because we have found abnormal immature B cells with pretty high CD45 expression. And then we take those cells and we put those into a CD19 and or CD10 plot. So we're capturing all of those. And then we kind of have to like have a place to start. So we put those cells into a CD38 versus CD10 plot with the thought that a lot of these abnormal immature B cells are going to have a decreased 38 expression and maybe even an increased CD10 expression. And I know they don't all fit into that box, but we need a place to start, so that's where we start. So we identify what we call the area of concern, and then we put those into a bunch of 2D plots. And this is what we get. And it, you know, do you see anything like overwhelmingly abnormal? I don't know. You have to sort through it. So if it was me looking at this the first time, I would probably go for this clustering of cells here, put a gate around those. But what I can see right away is I'm probably cutting off that population. It probably extends into these normal hematogones here. And then I've got a mixed population. I've got this that isn't part of the same population. So I'm going to go further. I'm going to expand this area of concern gate. And so what do I have here? I don't know. I have this population that sort of clusters here, so let me put a gate around that. And is this something abnormal? Well, let's put it into the context of normal hematogones. We have our stage 1 hematogones colored in a light purple, our stage 2 in a light blue, and then the mature B cells in the dark blue. So they do have some increased CD34 expression, some increased CD19 expression. The 81, though, is not decreased like I would expect it to be or hope it to be. And 38 is not very decreased, maybe a tiny bit. But I do have positivity here with the CD66, 13, and 33. So that leads me to believe that it's an abnormal population. And this is pretty convincing, but you'll see later, tube 2 is not convincing at all. So we put this into a T-SNE template. And with our T-SNE template, we can't put all million cells into the T-SNE tool because it would just take too long and it would just be sort of a mess. So we have to start somewhere. So we're going to start again with the low side scatter region and the CD10 and or CD19 positive cells. But then we're just going to throw that into a T-SNE algorithm. So what we get is this, and you can see these are stage 1 hematogones because I have them colored somewhere else, stage 2, and mature B cells. And we always keep this empty gate on the plot. So we use FCS Express for our analysis, and this is what my FCS Express window looks like. And what I do is I float that gate around the various islands of the T-SNE plot. And by the way, I realized that I didn't go over T-SNE in the very beginning, but there's a great talk about it yesterday. So basically, with the T-SNE algorithm, we're looking at many parameters, high parameter data, which in our case, it's just 10 parameters, but still high parameter data, and we're condensing it down into a 2D plot. And if two cells are not similar, the algorithm will push them apart from each other. And if they are similar, they'll get grouped together in islands. So what I do when I analyze, and let's see if I can get it to play, is I just float this gate around the various islands. So I would start here, and then I have to look at the 2D plots beneath it, and I have to look at their phenotypes. So that island was not what I was looking for. It didn't express 34 or 10. It didn't look like anything abnormal. So floating to that peninsula, that wasn't anything either. But But when I float to this island down here, I can see that this is an abnormal population based on the marker expression below. So what I have is a 0.023% of WBCs as my abnormal population. And I have, that same population that I found with the traditional analysis, the bright 10, the bright 34, the aberrant expression of 66C, 13, and 33. But it was way easier to get there. I didn't have to do the sequential gating where I have to drill down and down and down. I was able to isolate the population fully on one plot and also be pretty confident that it's not a hematogone population because it's fully separated from the other hematogone populations. So if we look at tube 2, again, we start with the low side scatter region. So here we're going to plot CD22 and CD24 against our exclusion markers. So we're going to take those 22 and 24 positive cells that are negative for our exclusion markers, put those into a 38 versus 10 plot, and again, pull up that area of concern, the 38 dim, 10 positive region. And with our traditional gating and our traditional gating strategy, I already knew from tube 1 that our abnormal population sort of bled into the normal hematogones. So I opened this up right from the start. And then I have, all of this, which includes all of the normal hematogones. So where do you go from here? Luckily, from tube 1, I knew that our population had bright CD34 and slightly decreased CD38. So I just put a gate here. And you can see it's kind of mixed. I have some other stuff in there. So I'm going to go down a level in my sequential gating. And unfortunately, like I said, if I had just looked at this tube, I wouldn't actually think that there was an abnormal population here because I don't have any CD73 expression, I don't have any 123 expression, and I don't have any 304 expression. So I would have probably missed this if I was just looking at this tube alone. But I see a little bit of a split with CD22, so I'm just going to put a gate on these 22 brighter cells. And then if I put it into context with the normal hematogones, I can see that it's probably that same population that I found in tube 1, which has the bright 10, the bright CD34. But again, this was tricky, and this sort of made us question whether we were making something up that wasn't there, because when you look at 5 of these a day, you can start to question yourself. So we put it into the T-SNE, tube 2 into the T-SNE. And these colors are sort of meaningless on this particular T-SNE plot, but I floated my empty gate onto these various islands to see if anything looked abnormal. And sure enough, this little bottom island was 0.034% of the WBCs and showed that same expression of 34 and 10 and 38 that our tube 1 found. So we signed this out as abnormal immature B cells at 0.03% of white cells. And, without our markers of aberrancy, 123, 73, or 304. But we did have that increase in CD10, increase in CD19, et cetera. And we did correlate with clonoSEQ, which detected 98 residual clonal B cells per million nucleated cells. And just real quick, when we validated this assay, we did a quick study or a small study of 20 samples, 15 known positives, 5 known negatives, and we compared the T-SNE analysis to the traditional analysis. And what we found is the T-SNE analysis was able to identify islands of abnormal cells in 15 out of 15 known positive samples. And in the no negative samples, we had to evaluate roughly 5 to 13 islands, but found nothing of concern there. So the qualitative results were concordant in all 20 samples. But the biggest thing for us was it eliminated the need for the sequential gating where you have to drill down and down and down to fully isolate the population. So we were able to eliminate the need for that hierarchical gating in 15 out of 15 positive samples. And here's just a look at all 15 cases. These are all at MRD level, and you can see that it does a really good job of fully isolating even below our limit of quantitation that we have stated for our assay. This one is 0.006. And these are our 5 no negatives. When evaluating these different islands, we found hematogones, mature B cells, plasma cells, and some basophils and some debris, but nothing of concern. And so to conclude, this is a really exciting tool to take high dimensional data and display on a 2D plot. And it really eliminates the need for that sequential gating and a multi-level hierarchy. And for us, it gives us the confidence that if something separates into its own island, that it is separate or different from hematogones. And looking forward, we just purchased spectral cytometers, so we think that T-SNE lends itself really well to spectral flow, and we're also looking into the possibility of AI applications, so this would lend itself really well to that too. And I would like to thank Lori Soma because she's the hematopathologist that guides everything we do as far as MRD testing in our lab.
Questions?
We looked at it and they optimized the methods for sequencing more cells in a faster method that fits the biopsy.
Have not. Nope. It was asking if we've looked into Opti T-SNE, and no, because it was enough of a, a stretch to learn the concept and just get the regular T-SNE going. But we'll have to go back and look at that. Thank you.